I'll be presenting today's Radiopedia.org case in radiology, chalk stick fracture. Case courtesy is demonstrated here, and the case link is in the description below. Presentation: we have a 55-year-old male with ankylosing spondylitis who presented to the emergency department with severe neck pain after falling from a height. Taking a look at the CT scan of the C-spine, we note features in keeping with ankylosing spondylitis, characterized by ossification of the spinal ligaments and fusion of the facet joints, as well as diffuse skeletal hyperostosis with bridging syndesmophytes and sclerosis of the upper and lower end plates of the vertebral bodies. There's also a complete oblique fracture line through the ossified anterior longitudinal ligament at the C6 upper vertebral body that extends posteriorly to the posterior cortex, as well as both ankylosed facet joints at this level, denoting the chalk stick fracture. Taking a look at the MRI of the C-spine, we note that there's paravertebral soft tissue edema from C2 to the upper thoracic levels. This focal marrow edema is noted along the fracture lines, extending through the facet joints. The vertebral height, disc height, and bone marrow signal are normal, the cord signal is normal, and there's no evidence of epidural hematoma. The canal and neural exit foramina are capacious with no high-grade stenosis. Normal flow voids are demonstrated in the vertebral arteries. This case demonstrates findings of ankylosing spondylitis, which is a high risk for displaced fractures due to increased stress secondary to decreased flexibility after trauma. This injury is known as chalk stick or carrot stick fracture. These classically occur in ankylosing spondylitis, but can also occur in other settings, such as diffuse idiopathic skeletal hyperostosis, or possibly ossification of the posterior longitudinal ligament.